Hello friends, let us now learn some important points about mandibular fractures. In the mandibular fractures, first, the most common site of mandibular fracture is condylar neck. Condylar neck is the most common site of mandibular fracture because it is a weak point and it occurs due to the blow from the side. There are two named fractures in mandible. One, it is Gosman fracture, where the force from the site of the blow is transmitted to the distant site, whereas butterfly fracture, where the segment of the mandible is detached in the canine region. Here the segment of the mandible is detached in the canine region. Diagnosis is we should give a panoramic radiograph is advised, and Torn's view of X-ray is also advised. Treatment is restoration of dental occlusion is the main foundation for mandibular fracture. There are two types of mandibular fracture. Two types of treatment can be given. You can either do and two types of treatment can be given here. You can either do open reduction can be done, which is a preferred treatment, and closed reduction can also be done, but closed reduction is not preferred because closed reduction can lead to ankylosis. The mandibular fractures are given by a classification, that is Dingman's classification. Then second thing is zygomatic bone fracture. Zygomatic bone fracture or tripod fracture. This is the second most common facial fracture. It is most commonly seen in the middle one-third of the face, that is nose, in the nose more commonly than the zygomatic bone. So this zygomatic fracture can be classified into three types. One, there is zygomatico-frontal fracture, zygomatico-temporal fracture, and infraorbital fracture. So the clinical features vary depending upon the type, but here you will see orbital fractures. Sorry, first we will see the picture. So this is the picture of skull. So in this fracture which you can see between the zygomatic and this is the zygomatic bone, this is the frontal bone. Between zygomatic and frontal bone, this fracture is zygomatico-frontal fracture. This is the zygomatic bone and this is the temporal side. Here you will have temporal bone also. This fracture is zygomatico-temporal fracture, and this is the fracture which is present below the orbit. Now first we will see orbital features, which include ecchymosis of periorbital region in 2 hours of injury, which is pathognomic. You will see the deformity which is seen in the infraorbital margin, and there is restricted ocular movements, especially inferior rectus. Periorbital edema can occur, diplopia can occur. Then others like flattening of malar prominences, anesthesia in distribution of infraorbital nerve because of infraorbital nerve injury, especially in infraorbital fractures, and in trismus due to zygoma which is impending on the coronoid process of mandible. So all these are the main clinical features. So if you see the diagnosis, before that there is oblique palpebral fissure is also seen. Then if you see the diagnosis, the X-ray is done, Waters view is preferred, and CT scan is the best. Treatment is, if it is undisplaced fracture, no treatment is required. If it is a displaced fracture, we should do open reduction and internal fixation. Then we have mid-face or Lefort fractures. In mid-face or Lefort fracture, we have first three types, which is number 1, which is called as Lefort 1 or Lefort 2 and Lefort 3. First we will see Lefort 1, or also called as transverse urine fracture. Here this is the skull, okay. The fracture line will lie parallelly and above the soft palate. This is the soft palate. Here the fracture line lies parallelly to the soft palate, and thus it separates the alveolus from the palate. In Lefort 2, here it is passes, the fracture line here passes through the root of the nose, lacrimal bone, floor of the orbit, and also in the upper part of maxillary sinus. Okay, so this is the pyramidal shaped fracture which is Lefort 2. In Lefort 3, you will see that there is complete dysfunction of facial skeleton. Here the fracture line is from the center. If we see, the fracture line is from the nasal bridge, then nasal septum, then ethmoid bone and orbit, and also frontozygomatic suture is involved in this Lefort 3. Then Lefort 1, here the fracture line runs parallel to the palate and it separates the alveolus from the facial skeleton. And here in Lefort 2, this is a pyramidal shaped structure where the fracture line passes from the root of nose, lacrimal bone, floor of the orbit, upper part of the maxillary sinus and pterygopalatine plate. Okay, here the orbital floor is mainly involved, right, because here orbital floor is mainly involved. Then in Lefort 3, there is complete dysfunction of the facial skeleton from the skull, and there is parallel line occurs through the nasal bridge, fracture line occurs through the nasal bridge, septum, ethmoid bone and bone of the orbit to the frontozygomatic suture. So treatment is interdental or intermaxillary fixation is done. So this is done to re-establish the dentoskeletal relationship and to immobilize the fracture bone, and we should ensure that normal post-operative occlusion. This is about midline fracture or Lefort fracture. Then after this Lefort fracture, the next fracture which is important is, one more important thing is Lefort 2 and Lefort 3 are associated with CSF rhinorrhea. On Lefort 1 X-ray, if you see, you will see presence of floating plate and teeth. Lefort 2, you will see presence of floating maxilla, right. So next, if you see the next fracture which is important, the next fracture is, we have fracture of nose. So in the fracture of nose, the most common bone which is fractured the most common facial bone fractured is fracture of nose. It is of 3 types. Class 1, Class 2, Class 3. Class 1 is also called as Chavalet fracture. Class 2, Jarjave fracture. Class 3 is also called as naso-orbito-ethmoidal fracture. Class 1 fracture is a Chavalet fracture. You will see that this is a depressed fracture, and fracture line will run parallel to the dorsum of nose and also nasomedial suture line. It runs through the dorsum of nose and nasomedial suture line. Nasal septum is not involved. Nasal septum is only involved in severe cases. No gross deformity is seen. Treatment is, you will have to do fracture reduction immediately after 5 to 7 days once the edema settles. So if you see, this is the fracture which you can see, which is parallel to the dorsum of the nose and nasomedial suture lines. So it is actually a vertical fracture which you can see. So this is a vertical fracture, is Chavalet fracture. Then we have Jarjave fracture. Jarjave fracture will involve the nasal bone, frontal process of maxilla, and it also involves the septal structures also. So as a result, this Jarjave fracture causes septal deviation. Ethmoidal labyrinth and the orbit are spared in this Jarjave fractures. Ethmoidal labyrinth and orbit are spared. Then here cosmetic deformity will be present. Treatment is, you'll have to do closed reduction of the nasal bone should be done after the edema subsides, that is in 5 to 7 days. And then along with that, even if it does not subside, even if it does not resolve properly, then you should do open reduction for septal deformity. Septoplasty is done if the patient is more than 17 years, because here there is septal deviation, so you should correct it. So this is the Jarjave fracture. Then finally we have class 3 or Naso orbital fracture, which are caused by high velocity trauma. Here ethmoid labyrinth is involved in Naso orbital fracture. Orbital ethmoidal fracture, ethmoid labyrinth is involved. As the name says, there is multiple fractures of ethmoid and orbit is seen, and these may even extend into the sphenoid and suprasellar region. CSF leak and pneumocranium is also seen. Treatment is, we can do surgical treatment should be given. Immediate surgical treatment is necessary. Then the most common symptom of nasal fracture is epistaxis. Here external nasal deformity is important, and nasal obstruction should be due to the blood clot. Palpation, on palpation you will see presence of tenderness and crepes, and watery nasal discharge is seen, which is CSF rhinorrhea. Then so what is CSF rhinorrhea? We will learn some important points about the CSF rhinorrhea. CSF rhinorrhea, here there is flow of CSF occurs from the nose freely. The causes are, these can be traumatic causes, where here it occurs immediately or delayed within 3 months of injury. In the traumatic causes, we have accidental causes and iatrogenic causes. Accidental causes include Lefort 2, Lefort 3 and maxillary fractures, and it also involves the transverse fracture of temporal bone. Whenever there is class 3 nasal fracture, that also causes CSF rhinorrhea. In iatrogenic, it can be due to headlight or intranasal surgery like polypectomy, endoscopic sinus surgery, craniotomy, transsphenoidal hypophysectomy. All these results in CSF rhinorrhea. Then atraumatic causes can be due to, it can be due to increased intracranial tension like tumors, hydrocephalus, or destructive bony lesions like granuloma, or it can be due to normal pressure leaks also, like it can be due to congenital dehiscence of the nasal roof. It can be due to congenital dehiscence of the nasal roof, or facial atrophy can result in these CSF rhinorrhea. Normal pressure leaks in congenital dehiscence of nasal roof, facial atrophy, or osteomyelitic erosions. So most common cause, if you were asked, they are head injury previously, but nowadays the most common cause is iatrogenic traumatic surgery. All these causes will cause escape of CSF will occur from anterior cranial fossa or middle or posterior cranial fossa. It can occur from anterior cranial fossa, that is from frontal sphenoid or ethmoidal sinus, or from cribriform plate, or we can even see the flow of CSF from middle ear via eustachian tube. And if this escape of CSF can also occur in middle or posterior cranial fossa, which involves the mastoid cavity and the sphenoid cavity. If you see the clinical features include unilateral clear watery discharge is seen, which is dripping or down on looking down, and this clear discharge will increase on coughing, sneezing and exertion. Diagnosis include, on examination we will see the reservoir sign. After being supine position, the patient is made to sit up in flexed position with neck flexed. The patient is made to sit upright with neck flexed. Then you will see sudden gush of fluid rushing through the nose. Then you can diagnose it has CSF rhinorrhea. Then we have handkerchief test. This handkerchief test, in this handkerchief test we will when you put the secretions in the handkerchief, then you will see that the handkerchief, if the handkerchief stiffens, then it is due to rhinitis due to mucosa, or if the handkerchief is not stiff, if there is no stiffness occurs, then it is due to CSF rhinorrhea. Actually, in the rhinitis, the stiffness occurs due to the presence of mucus in the running nose. Because of the presence of mucus like material, stiffness of handkerchief occurs. But due to the presence in CSF rhinorrhea, Because it is clear fluid, you will not see any stiffness. Then we also have one more test. We have one more test called as double ring sign or halo sign or double target sign is seen. In this double ring or halo sign or double target sign, you will see central blood red spot is seen, which is surrounded, central blood red spot is seen, and this is surrounded by the peripheral lighter halo. It is surrounded by the peripheral lighter halo, and this peripheral lighter halo is due to the cerebrospinal fluid. So these are the important things. And one more diagnostic feature is you can do nasal endoscopy with fluorescein dye can be done. Then the biochemical examination, you will see glucose more than 30 milligram percentage will confirm it has CSF. In CSF you will see presence of increased chloride, and you will also see presence of beta transferrin. If you see beta transferrin on electrophoresis, then this is pathognomic. This is only best test which is available to confirm CSF rhinorrhea. With this beta transferrin is also present in cerebrospinal fluid, perilymph, and it is also present in aqueous humor. Then we also have one more protein called beta trace protein, which is specific to CSF. This beta trace protein is secreted by meninges and it is used in Europe. Imaging of choice is for diagnosis of site of leak, it is T2 weighted MRI. And treatment, in early cases we do conservative measures, give bed rest to the patient, increase the head end of the bed, give stool softeners, avoid nose blowing, sneezing or staining. All these are avoided. Then in early cases acetazolamide can be done, which will decrease the CSF formation. Prophylactic antibiotics are given to prevent meningitis. And surgery, if you see, it is rare. Neurosurgical intracranial approach can be done, or extradural approach, or we also have transnasal endoscopic approach. So these are the important points about the CSF rhinorrhea and all the fractures involved in the skull region. Thank you for watching.